Mr. Chairman, dear colleagues, today I'm going to talk on the topic surgery and interventional management of neurogenic lower urinary tract dysfunction from urologist perspective. I'm sorry I cannot attend this important meeting, but I hope this video can bring you some valuable information in the management of lower urinary tract dysfunction in spinal cord injury patients. Lower urinary tract dysfunction are frequently encountered in patients with neurogenic lesions. Among these diseases, neurogenic lower urinary tract dysfunction in spinal cord injury patients are most challenging and difficult to manage. NLUTD is usually classified according to the bladder contractility, bladder neck function, and the external sphincter function. The NLUTD may be failure to store, failure to empty, or combined failure to store and empty. Our previous study also revealed different NLUTD in patients with different level of spinal cord injury. The higher spinal cord injury level, the higher rate of detrusor overactivity and urinary incontinence. In management of NLUTD, the first one is to correct complications, then consider to improve quality of life. Individualized treatment strategy for each patient is necessary. NDO can be treated effectively by anticholinergics. Long-term efficacy and safety of antimuscarinic therapy for NDO is well documented. The other medical treatment for NLUTD include to reduce bladder neck hyperreflexia by alpha blocker and to reduce striated sphincter spasticity by skeletal muscle relaxant, nitric oxide. There is no success been attained with drugs for improving detrusor contractility. An early start of therapy to help safeguard of the kidney function is important in treatment of NLUTD in the acute stage of spinal cord injury. This slide shows reduced frequent detrusor contractions and the VU reflux after oxybutylin therapy in a child with MMC. In EAU guideline for NLUTD, parenchymal mimetics are not recommended for underactive detrusor, and the drug treatment for stress urinary incontinence is also not suggested. Intermittent catheterization is the standard treatment for patients who are unable to empty the bladder. Aseptic intermittent catheterization is the method of choice. Although CIC was instructed for bladder management in spinal cord injury patients, in the beginning, patients usually converted to the other bladder management, such as indwelling a catheter, condom catheter, or other methods. In Taiwan, patients with a duration of spinal cord injury for more than 5 years usually chose indwelling catheter or cystostomy more often than CIC. For spinal cord injury patients, the NDO and the DSD frequently to antimuscarinic therapy, combined antimuscarinics and beta-3 agonist might be a good combination to treat NDO in spinal cord injury patients. After spinal cord injury, the bladder afferent nerves turn to be C fiber predominant. We can use intravesical valinoid on afferent nerves or use botulinum toxin A to inhibit the release of acetylcholine from efferent nerves. Intravesical botulinum toxin A injection has been demonstrated effective in restoration of urinary incontinence and remains durable up to 9 months. The EAU guidelines also recommended in patients with NDO and not respond to antimuscarinics. Botulinum toxin A detrusor injection is recommended. Before detrusor Botox injection for spinal cord injury patients with NDO, we must confirm a diagnosis of neurogenic detrusor overactivity and confirm failure on anticholinergic therapy. There are different injection methods at different numbers of injection sites in spinal cord injury patients with NDO. After Botox injection, the bladder capacity can increase and the detrusor contractility decrease. Good therapeutic effects on the reduction of urinary incontinence were noted after injection of 200 or 300 units of Botox in diagnosis in the detrusor of patients with NDO. As shown in this slide, detrusor overactivity can be suppressed after detrusor Botox injection. The therapeutic effect can last for 9 months, and 200 or 300 units do not differ in outcome. Past clinical trials all reveal that dose of Botox 300 and 200 units do not differ in the outcome of NDO in spinal cord injury patients. The effect of the Botox on spinal cord injury patients with NDO had been well demonstrated in several large cohort studies and randomized double-blind placebo-controlled trials. After week 6, Botox 200 unit and 300 unit significantly reduced urinary incontinence episodes per week compared with placebo. The initial long-term study also showed that repeat Botox injections are as effective as the first one injection. Repeated Botox injection every 6 months showed the therapeutic effect could be maintained at the end of the repeat injection, indicating the treatment period can be longer. Comparing the effect of Botox on the occurrence of NDO, we found that the occurrence of involuntary detrusor contractions during cystometry was less than in the 300 unit group than 200 unit group at the endpoint, suggesting the dose of Botox could be escalated to 300 units if 200 unit treatment fails. However, the improvement of the incontinence severity was not consistent after each injection, and the patient's adherence rate to repeat Botox A injection was low. Our study did not demonstrate that repeat Botox injection led to improvement in glomerular filtration rate over a 24-month period. Urethral Botox injection can also facilitate bladder empty, but patients' urinary incontinence will usually be exacerbated. Patients with DSD and treated with detrusor Botox injection had greater quality of life improvement than those treated with urethral Botox injection. It is important to screen the patients at high risk. If a DLPP is more than 40 centimeter water is noted, the upper urinary tract might be endangered. So this is an example of high-risk spinal cord injury patients. Patient had cervical spinal cord injury, tetraplegia, prolonged enduring catheter, high detrusor lip point pressure, and the presence of DSD and AD. Video urodynamics is the gold standard for invasive urodynamic study in spinal cord injury patients with NLUTD. In chronic spinal cord injury, patients might develop the following urological complications that need special attention, including urinary tract infection, hydronephrosis, stone formation, contracted bladder, VU reflux, incontinence, urethral fistula, abscess formation, and even bladder tumor. This slide shows the bladder stones and the VU reflux in patients with chronic spinal cord injury and NLUTD. The complications can occur in any level of spinal cord injury. There are different surgical treatments for chronic spinal cord injury, especially to correct the urological complications. The purpose of surgical treatment are to facilitate bladder empty, to improve bladder storage, and to improve quality of life. The principle of bladder management in chronic spinal cord injury patients should follow the priority order of first, to correct urological complications, to normalize lower urinary tract function, and to improve quality of life. Chronic spinal cord injury patients, especially with quadriplegia, who cannot perform CIC, transurethral sphincterotomy, it can decrease the urethral pressure and lower the voiding pressure. After external sphincterotomy, there was a significant improvement in AD, UTI, and a significant decrease of PVR. Intravesical pressure can be reduced after sphincterotomy. Of course, transurethral incision of the bladder neck is effective in restoring spontaneous voiding, increasing maximum flow rate, and decreasing PVR in high-level spinal cord injury patients. TUIBN also leads to improvement in reducing bladder outlet resistance, reduction in occurrence of AD episodes, and improvement of quality of life. For patients with diffuse underactivity and a tight bladder neck on abdominal straining to voiding, surgical treatment such as TUIP or TURP can also reduce the bladder outlet resistance. Spinal cord injury patients may develop to a low compliant bladder. Some patients eventually require surgical intervention in spite of the aggressive medical therapy. Augmentation enterocystoplasty with an iliac segment provides effective and safe therapeutic outcome in spinal cord injury patients. However, problems with UTI, reservoir calculi, and the new onset upper urinary tract urolithiasis still need to be solved. After enterocystoplasty, intestinal mucosa become flattened, decrease of gland and evacuation degenerative changes with time. The bladder capacity increased, bladder pressure decreased after augmentation. The hydronephrosis at baseline can also resolve after augmentation enterocystoplasty with or without urethral implantation. In a study of a real-world experience with augmentation enterocystoplasty, we found that high patient satisfaction but high complication rate were noted. About 80% of patients still need CIC after augmentation cystoplasty. Bladder auto-augmentation offers an alternative procedure for augmentation enterocystoplasty for spinal cord injury patients with high pressure and low compliant bladder without resection of the intestine. Bladder auto-augmentation, we only do myomectomy and leaving the bladder mucosa intact. For patients with contracted bladder and high-grade VUR, we can make a continental urinary reservoir, such as using an augmentation enterocystoplasty plus a continent catheterizable stoma to create a low-pressure continent urinary reservoir. Some patients may have severe contracted bladder, high-grade VU reflux, and intrinsic sphincter deficiency, and have severe urinary incontinence. Then a cork pouch continent reservoir for contracted bladder and severe ISD can also provide a low-pressure reservoir, anti-reflux, and a continent stoma. For patients with cauda equina lesion, diffuse areflexia, and intrinsic sphincter deficiency, a suburethral sling can restore urinary continence, both in male and female spinal cord injury patients. In severe incontinent spinal cord injury patients, an artificial sphincter such as AMS 800 implantation can provide a totally continent rate of about 77 to 90%. Active urological management to improve quality of life and to treat urological complications in spinal cord injury patients is mandatory. Because the bladder and the urethral function change with time in patients with NLUTD, patients should be regularly followed up for their lower urinary tract dysfunction, and any urological complications should be adequately treated. All patients should receive lifelong surveillance to prevent development of urological complications and undesired lower urinary tract symptoms. In addition to the health examination of spinal cord injury patients at hospitals, we also have health surveillance at community throughout the country. We provide educational courses for them to understand the potential urological complications, proper bladder management, and new technologies to improve their urinary tract quality of life. Thank you for your attention, and hope you can visit Hualien, Taiwan in the near future, of course, after the COVID-19 pandemics. Thank you.